Good afternoon, everyone. So today we're going to hear from two recent participants in the Harvard Macy program for postgraduate trainees as future academic clinician educators. This program is co-sponsored by our school and is in its 7th year. This past year, the program welcomed 65 residents and fellows from the U.S. and Canada. Dr. Karani serves as a co-founder of the course, and each year the IME is proud to select 2 scholars who receive tuition reimbursement for the course based on the quality of their project submission. Those 2 scholars are also invited to present IME Medical Education Grand Rounds, and today we are pleased to welcome Drs. Helen Chung and Nico Volz, who took the program in 2018. I'm going to introduce them both. We'll have Dr. Chung present first, answer questions, and then we'll switch over to Dr. Volz. So Dr. Helen Chung is a 4th-year neurology resident at Mount Sinai Hospital and chief resident for academic and curricular affairs. Before attending medical school, she spent a year as a Match Corps Urban Education Fellow, teaching and developing curriculum for high school students. During residency, her medical education research project in the linguistic analysis of personal statements studying why medical students choose to pursue neurology was selected for a platform presentation at the AAN annual conference. Next year, she will be pursuing her interest in neuromuscular medicine as a neurophysiology fellow at Stanford. Dr. Volz is a 3rd-year emergency medicine resident at Mount Sinai who has a particular interest in medical education. Since medical school at Oakland University William Beaumont School of Medicine, he has worked on patient and staff safety projects. He continues to work on quality improvement and patient safety research throughout residency and hopes to continue doing so in the future. Welcome to you both, and we'll turn things over to Dr. Chung.
So today I'll be talking about improving the neurology EMG curriculum, a hands-on approach. I don't have any disclosures to talk about. In terms of the objectives of the lecture today, I want to help everyone understand the challenges of incorporating an outpatient EMG curriculum into our neurology residency, as well as discuss strategies for active learning during residency. A little background into what EMG is, why this is important. So for the non-neurologists in the room, electrophysiology studies play a large role in the evaluation of patients, specifically in neuromuscular disorders, and it's really an extension of the neurological exam. We take this data and we put it together as part of the whole picture to understand what's going on with our patients. And the primary goal of these studies is to localize the lesion, all as neurologists love to do. Neuropathy, myopathies, neuromuscular junction disorders like myasthenia gravis, all of these can really be elucidated by doing electrophysiology studies. So just to give a brief picture about what I'll be talking about. So at the top left, the nerve conduction studies, usually a fellow, supervised by an attending is the one performing the study. There's the equipment to the left of that picture, and then the patients in the room while you, it sounds terrible, but you give them a shock, and then you record the nerve conduction that comes back. In the second part of the study, the EMG, the electromyography, you take a needle and you stick it into the muscle belly so you can see if there's any irritation, any denervation to them. In terms of what's already been studied in the medical literature, in 2018 there was a survey that was conducted with program directors as well as residents, basically seeing where everyone was. So they specifically looked at how these program directors and residents thought their students were meeting the ACGME Milestones. Specifically, they focused on level 4, where the resident has advanced so that he or she now substantially demonstrates the milestones targeted for residency, and this level is designed as a graduation target. Not necessarily a requirement, but the target. So program directors thought that only 75% of their residents met level 4 milestones in EMG, and specifically they identified inpatient service demands, as well as lack of exposure to the neuromuscular subspecialty as a reason why perhaps their residents weren't meeting these milestones. Some of the kind of different ideas that were reported in the literature at University of Michigan, one of the attendings there developed kind of an online self-study curriculum that was hoping to address that kind of deficit in, we don't have enough time for our residents to learn all these outpatient procedures. Perhaps they could look at this self-study curriculum and take that forward with them. They did notice that about like a 10 percentile point higher average on their national in-service exam, known as the RITE exam. So it did show that that was beneficial in their part. And hopefully, it was also addressing standardized instruction and feedback that can be challenged in a clinical setting. Typically, how residents learn EMG is really just showing up to the lab, almost apprentice style, where you sit in the room with the fellow or the attending, and you see the patient together, the fellow performs the procedure, and most of the time you're watching in the background, and then discuss the case after the patient has gone. And of course, since it's not standardized, whatever the patient comes in with, whatever diagnosis you're talking about is what you're learning that day, rather than a formalized curriculum. One more study I want to point out, they also were trying to figure out how we could standardize this experience and activity better. They developed an EMG direct observational tool that basically broke down, I'm going to show the actual tool because I think it's better to understand. They broke down the whole experience into the preparation the resident had to take, the actual performance and interpretation of the multiple parts of the study, but also report writing, coding and billing, communication skills, and professionalism. And I thought this was helpful because it really made me understand like how much goes into just one of these encounters, and how difficult it can be for someone on the fly without any curriculum to really teach the residents the whole picture of how this patient encounter should be led. So I wanted to see what our residents felt like they needed in terms of the EMG curriculum. So I just sent out an online survey just through SurveyMonkey. About 38% people responded, and this level ranges, for neurology, the first year is medicine intern year, where they're not part of the neurology curriculum, and then the 3 years after that they are. For us here at Sinai, our neurophysiology curriculum is 1 month in our PGY3 year. It definitely varies from program to program, but that's how ours is set up. And the people that responded to this survey, some of them were PGY2s, so they haven't even necessarily experienced or been able to experience any neurophysiology as an outpatient. So when asked about where they thought they might land in terms of the milestones currently, for neuromuscular medicine, which I'll show you shortly, they thought they were more level 1, level 2. So just to read that quickly, they could recognize a neuromuscular disorder, but most importantly, in the level 2, if you look at the very bottom, it says you can order the study. You don't even move to level 3 where you can interpret the results of the study. So that was a little, striking for me to notice. I already kind of mentioned it, but basically level 4 is our graduation target, and level 2 and 3 is meaning that, understandably for a PGY2, they would be somewhere like mid-residency level, like a level 2, where they're interested in gaining more experience and exposure. So then I asked the question when I showed them the neuroconduction study EMG milestones, where they think they land. Of course, we're hoping they're shooting for level 4. A lot of people actually said level 1 and level 2. Where they could explain the non-technical terms of the neuroconduction study, they could use appropriate terminology, but not many people felt like they could accurately describe the data or list common disorders that were related to this data. And our goal is to interpret the studies, describe common pitfalls, and formulate basic plans. Because I think, as any physician will understand, even, for example, in radiology, you get the report, but with every neurologist, we're supposed to look at the imaging and understand how to do that. And I hope that we'll be able to do that with the neuroconduction study as well. And so then I asked some more just general questions. How confident were you in your ability to interpret raw data and not just read the impression? Nobody agreed. Everyone disagreed that they didn't feel confident. They didn't have confidence in interpreting raw data. They also didn't have confidence in performing the EMG study. To be fair, performing an EMG study can be something that's more fellow level. So that I was not surprised by. What problems do you see in the current curriculum? What suggestions? So I left it pretty free so that people could give me their honest opinions. So what I heard was they would appreciate dedicated time to explanation of basic EMG data, interpretation and disease correlation, that it felt like shadowing. They would recommend more interactive and supervised curriculum with learning goals and resources. There wasn't a formal curriculum for this type of almost apprentice-like interaction. Perhaps they would like a required EMG training session before you even kind of started embarking on elective time. And the last one, when they show studies, it can be hard to see the numbers. I can never read the numbers because it's so small on the screen. People just assume you know everything. And I think that quote just made me, I think we've all felt that way if you're shadowing in a situation that you don't feel comfortable speaking up and asking the questions because you don't necessarily feel like you're part of the main part of that interaction. So what did I plan to do after I heard what our residents had to say? I wanted to bring EMG back to the basics so that that feeling of I don't even know where to start asking questions was addressed. I wanted to create an interactive learning experience where people weren't just sitting in the back of the room and on their phone looking up what the normal data range would be for this data point. And I wanted to introduce a more formal curriculum that all the residents know about. So I wanted to do kind of a two-prong approach to my intervention. So one was to create just simply an EMG packet that had goals and objectives for the data assessment of pre-test and post-test and satisfaction survey, but also just a list of neuromuscular education resources, a brief primer or introduction, so that if people felt lost, they could at least go back to that on the first couple days, as well as, and the main point for me was creating a clinical case worksheet that not only, I'm going to show it shortly, but not only have reference values, but really broke down the case in the way that even if they didn't understand during that encounter what happened, they could easily go back to the recorded data and talk to a fellow about it, perhaps when the patient wasn't there, and they could feel free to ask those questions. And then in addition to the actual encounters, I wanted to incorporate this. Neurology has from 12 to 1 every weekday, a Neurology noon conference, that's our main didactic. So I wanted to have resident and fellow-led lectures. And for it to be a back to basics lecture. So from a resident perspective, what is it that exactly confuses you? And this helps supplement, like I think unanimously, our favorite conference that we have is the Neuromuscular Case Conference, where our chair, Dr. Simpson, finds an interesting patient and brings them into the classroom. And this patient tells us their story from their perspective. And then after that, we take a look at their exam together, their neuroconduction studies and their EMG, and we talk about the treatment and diagnosis. This kind of interaction is, I think, the residents' favorite interaction, but breaking that down even more so that they can understand it without being just told what the information is, I think reinforces some of the active learning that people were interested in. So here's just an example of some of the highlights that I have from the packet. So I just listed the education resources. We have so many great resources through Levy Library that people don't even know are available to them. In addition, I created a primer base that had lots of pictures and diagrams about the physiology from Preston and Shapiro, one of the basic EMG books that we use. And then here's the example of a clinical case worksheet. So I expect the residents to ask a couple questions to get a little bit of the history. And then what's broken down in these tables is what usually is on the screen, abbreviated. So just knowing which muscle that you're sticking the needle in, the APB, as a PGY2, you may not know, that stands for abductor pollicis brevis. And I think that whole neuroanatomy learning curve is what creates a block to some of the questions that people can even start to ask. And then we have reference values listed so that people can understand when it's normal or abnormal. And then, the residents, they put in the data points that we get from the study, and then I hope that later on they go over with the fellow exactly what these values meant. And it's almost creating a primer so that they, once they've gotten comfortable, can actually help starting to write the reports themselves. So what did I do in terms of data collection? I tried to do a pre-test, a post-test, as well as a satisfaction survey. As with most of these medical education projects, since there's only 10 residents in the PGY3 year, and neurophysiology is spaced out for them in different parts of the year, so we're about halfway. I have about 50% of that class responding, but there are still a lot of residents that still need to go through the rotation. So I'm going to mostly focus on the satisfaction survey because it's a little difficult to get the data points from the pre-test and post-test at this point. So when asking if the primer or the clinical case worksheet were helpful, I think, mostly agreed, no one disagreed. In terms of a more structured curriculum, unanimously they agreed that was more likely for them to spend time in the EMG lab. In terms of confidence and ability to interpret the raw data, that was still a huge portion that was difficult for most people. The interest in neuromuscular medicine wasn't necessarily inspired by their time in the EMG lab. Neither was it mine. It's a lot about the clinical case conference and seeing patients that I think inspires a lot of doctors to do what they choose to do. It was easier to interact with fellows and attendings after being primed with the intro to EMG packet. some did find that that was true. Using the clinical case worksheet helped turn time into the EMG lab from passive to active learning. That was hit or miss across the board, so that was unclear. My confidence in peripheral neuroanatomy improved after my time in the EMG lab. 100% agree, and I'd like to say that's a win because not only for non-neurologists but also neurologists, peripheral neuroanatomy is hard. My likelihood in choosing neuromuscular medicine as a fellowship was increased. That wasn't the case. I'm likely to return to the EMG lab for future elective time. There was some people that agreed, and I think that's a win too, because basically you can choose your elective time. So if they were interested and felt like that was a worthwhile part of their education for their required neurophysiology time, I think it's great people would spend extra elective time by choice to come. So some of the challenges that I wanted to discuss that we had to face. There's a couple medical students in the room, but I think the brachial plexus, strikes fear in the hearts of most people. But this is the biggest barrier that we have. In order to understand the study, you've got to understand the brachial plexus. You've got to understand the peripheral nerves. And I think that portion is difficult to get across no matter where you are, because you just have to put the work in. But I think it's helpful that we're seeing an interaction where you're putting everything to use. It's not just in the anatomy lab or the cadaver lab looking at these nerves. It's like, well, if I check this, if I check the median nerve, then I'll know if they have carpal tunnel. Oh, perhaps it's the ulnar nerve. So I think this experience is really helpful for neuroanatomy general for all of our residents. But it was a reason that I think some people that didn't necessarily want to fully spend all the time there. And the other thing, the other point I didn't touch on with our neurophysiology rotation is that it's EEG for epilepsy and EMG, and residents have the freedom to choose how they spend their time with neurophysiology as long as they're in one of those labs. At the top is an example of an EEG, at the bottom is an EMG. Most of our residents do choose to spend more time with the squiggly lines at the top. I realize that's a biased statement because I'm here talking about EMGs, but I just think it's funny. I think, I would be interested to find out why that is. Perhaps because we, as a practice inpatient, have a lot more experience and time with EEG and seizures that people are interested and invested in trying to learn more. By the way, that's not even seizure at the top, that's chewing artifact. But that would be interesting to figure out. And if it's worthwhile for us to talk with our administration to figure out, should we make both of them required and just split the time rather than letting people freely choose if we want to have a balanced neuromuscular and epilepsy education. I spoke a little bit about the timing of rotations also. A lot of our education is done by the fellows. They're the ones doing the procedure and really breaking it down. One of the things that I would like to suggest is moving our rotations, like at least the EMG rotations, further in the year when the fellows are basically a lot faster at doing them and are able to instruct us more easily. Performing the studies themselves, because I think a lot of residents were interested in performing the studies themselves. I think this can be difficult when it's a true patient encounter that's already taking a long and painful time for the patient. I spoke with the fellows, and on Friday there's a little extra time for there to be separate sessions for basically residents to practice with the fellows or the residents themselves in performing the procedures. And once they practiced a couple, most of the time they'd be more comfortable. The fellows would let some of the residents do some of these sessions. And the data collection, I think, was a hard part of the study. I've learned that you can't buy resident buy-in. I offered gift cards, didn't work. So I think at the end of it, it's not like you can, when you're teaching someone, you don't want to bribe anyone to do anything. It's you just want to make something that residents think is worthwhile for their time and they were interested in. So I think that's a huge portion of making something sustainable, because I hope, this is my last year here and I hope this continues. And the pre-test and post-test, I think for me, when I created those questions, I was thinking from a perspective of someone who's going to do a neuromuscular fellowship, but I think I probably have to go back and reassess those questions because it's a short amount of time for someone to spend in the EMG lab. I think what our expectations of what our residents need to learn during that small time should probably be a little more focused, and I probably need some help from our neuromuscular department to figure out what questions those are. In summary, incorporating dedicated outpatient EMG education is a challenge for a largely inpatient residency. The neurophysiology curriculum that I hoped to develop was with objectives, resources, active learning tools for patient encounters, and specialized didactic sessions built into our normal noon conferences. And some of the preliminary results showed increase in confidence with peripheral neuroanatomy, which improved with time spent in EMG lab, which I was surprised by, and a likelihood to spend time dedicated to learning EMG now that there's a more structured curriculum in place. I just wanted to thank Dr. Susan Shin, my mentor, who is a neuromuscular attending, as well as Dr. Stephen Krieger, who's helped with a lot of medical education projects I've done. And I'd be happy to answer any questions.
So my name is Nico, I'm one of the PGY3s in emergency medicine. I've been working on a project called I'm Concerned, Speaking Up for Patient Safety in Emergency Medicine with my mentor, Dr. Bentley, who's also in the audience here today with us. I also do not have any disclosures. Some of the things we'll be talking about today are the project objectives, some background information, a pre-intervention survey, a simulation-based intervention, some post-intervention data, and then finally some limitations and next steps. So the project objectives were to assess emergency medicine residences' comfort in speaking up for patient safety events and compare that to a historical control study of trainees. We also aim to provide a simulation intervention and some tools for speaking up in the emergency department with the goal to finally reduce medical errors in the emergency department. So a little bit of background. In 1999, the Institute of Medicine estimated that there were as many as 98,000 deaths caused by preventable medical errors every year. One issue that they identified was the fear of speaking up to prevent such an error. Speaking up is defined as essentially moving from a passive bystander to actively intervening and preventing patient harm. In response to that, in 2015, Martinez and others created a validated survey to assess speaking up cultures of residencies. Some of the barriers that they identified was the fear of repercussion, disproportionate authority gradient, which essentially just means hierarchy gradients, excessive professional courtesy, and deficiency in resource or task management. So the original survey that was created by Martinez surveyed residents across 6 specialties. They were able to get 837 responses. Of those who responded, 75% were internal medicine residents, and the remainder were surgical residents from general surgery, neurology, OBGYN, plastic surgery, and neurosurgery. Emergency medicine providers were not part of this. The survey was comprised of 13 questions that asked participants to respond on a 5-point Likert scale, where 1 essentially means strongly disagree, to 5 meaning strongly agree. So here's the survey. Essentially, the way the survey is broken up is in 2 pieces. They designed the survey such that the first 6 questions address a speaking up climate safety environment, and the second portion of the survey addresses a speaking up about professionalism scale. So we distributed the survey to 3 different emergency medicine residencies across the country in 3 different states, in New York, Illinois, and California, via SurveyMonkey, via email. We received 101 responses from 188 surveys that were sent out, with a response rate of about 53.2%. All subjects at the time of taking the survey were emergency medicine residents, and the subjects that were available here in New York also were then signed up for a simulation. On 10 of the 13 questions, responses were aligned around the mean, and were really not different when you compare the original study cohort by Martinez to the emergency medicine responses that we received on our survey. There were 3 questions, though, that were significantly different. And 2 of those questions were in the first part of the survey about the speaking up culture for patient safety, and the last question was in the professionalism scale. So these are the 3 questions. Question 1 reading, I'm not responsible for the safety of others. Question 3 on the survey reading, in my clinical area it's difficult to speak up if I have a patient safety concern. And question 8, reading the unprofessional behavior of providers on other healthcare teams in my clinical area is none of my business. In the graph below, you can see in blue, those are the original responses from the Martinez study. And the three yellow bars indicate the three different emergency medicine residencies that responded to these questions. And you can see that the original cohort tended to agree with the above statements, where the emergency medicine residencies tended to disagree with all these statements. So why is that? We don't know. Possibly ED providers work in an environment where we care for patients based on where they're physically located, not based on what specialty they belong to. And so regardless of who the patient's admitted to or even who the provider is in the emergency department, we all have a sense of responsibility for really any patient who's in the department. I also think that speaking up is already part of the natural discourse that we have in the ED every day. A lot of patients who come in critically ill, for example, a patient who needs to be intubated fairly rapidly, will need to be assessed very quickly with limited amount of time, limited data. And so one person may suggest a combination of medications for rapid sequence intubation and set up for that. In the meantime, maybe someone else, a nurse or a resident, learns from EMS about past medical history for this patient that would warrant a change in medications for the intubation. And so that discussion has to be had fairly quickly, and you essentially have to speak up. So why do we need a simulation-based intervention? A lot of the responses, again, were neutral on the survey, and some of the indicators from the survey suggested that residents did not feel that speaking up really results in any meaningful clinical change. They also felt that it was difficult to speak up about unprofessional behavior, and they did not necessarily feel very encouraged about speaking up for patient safety concerns in their clinical area. So we created a trauma simulation. There were 3 participants of the simulation. The subject was assigned to be the role of the junior trauma team member. Then there was a senior trauma team member and the trauma patient himself. So the trauma patient came in with an anterior shoulder dislocation. An X-ray was provided, and the senior essentially tells the junior, just go ahead, set up for moderate sedation. We'll get the shoulder back in pretty quickly, get this patient discharged. It's a busy day in the ED. While the junior is setting up for the moderate sedation, the vital signs of the patient change and continue to deteriorate. He becomes more hypoxic, he becomes more tachypnic, essentially setting this patient up, in this case, for an unsafe procedure. The subject has multiple opportunities throughout the simulation to ask for further workup, and if they do so, they are provided with this ultrasound here, which demonstrates a left-sided pneumothorax. At this point, the subject hopefully will stop the sedation, will not continue even if the senior continues to pressure them to do so. So the subjects were then evaluated on a CUS method, which stands for Concerned, Uncomfortable, and Safety Issue. This is actually derived from the automobile industry, where any worker on the assembly line could, quote-unquote, stop the line if they saw an imperfection to a product. Subjects were then scored on a 3-point system. They received 1 point if they failed to recognize the safety issue. They received 2 points if they recognized the safety issue, voiced their concern, but did not stop the sedation. And they received 3 points if they requested a hard stop and prevented the procedural sedation. So of the 24 subjects that we've put through the simulation so far, 16 requested a hard stop, so about 2/3 of them, or 2/3. The remaining 8 voiced their concern but failed to actually stop the sedation, leading in a bad outcome. Subsequently, we debriefed with the subjects. We taught them the CUS method as well as some other methods that they can use in the department to voice their concern and speak up, essentially. We also asked them about some of the barriers that they perceived during the simulation. And what came up most commonly, even for those who did successfully stop the sedation, they still mentioned that there's a fear of being wrong. They didn't want to negatively influence their relationship with the senior in the room, and they were afraid that they just didn't have enough medical knowledge to call for a stop. So overall, the results for the survey indicated that there were a lot of neutral responses, and I think we can do better on raising safety concerns or raising professionalism concerns in the department. While most ED providers indicated that they will speak up if they do see an imminent error happening, they did not necessarily feel like the environment was very encouraging of doing so. And again, only 2/3 actually prevented a procedural sedation. That number would ideally be a little bit higher. And then some providers indicated that speaking up will not really result in any meaningful change. So some of the next steps that we have for this project are to put more subjects through the simulation. Some great feedback we actually got from the Harvard Macy course was to take the simulation, make it a little bit shorter, so that you can run someone in 5 minutes through the sim, pull them out of the conference real quick, because that was really one of the more difficult things to do, is to get people to show up for a simulation. We still aim to further identify and overcome some of the barriers to speaking up, and we will redistribute the survey to the post-simulation subjects to compare responses to the pre-simulation survey. The overarching goal will be to change the culture, hopefully provide all residents with the tools and a safe environment where they can raise a concern and don't feel, and then ultimately also just eliminate the idea of being wrong or incorrect. This project does have some limitations. The sim is a great tool to use clinically, but it doesn't fully replicate a true clinical scenario. We actually did, for a short period of time, run these simulations in our trauma bay at Elmhurst. But then the trauma patient comes in and it gets busy, and it's difficult to do that consistently. We have limited simulation data due to time constraints and availability, and we have a moderate response rate with the potential of a non-response bias. The project is generalizable to really any residency program that wants to use the same survey. It's available to everyone, and it can be used to further help identify some of the barriers to speaking up in really any specialty, and hopefully also implement some interventions. Some of the references, and that's all. I'd like to say thanks to the Institute of Medical Education for sponsoring our participation, and also thank you to my mentor, Dr. Bentley, Dr. Snow, Dr. Wong, and everyone who supported me. I'm happy to take any questions.